Hi everyone, Dr. Minasri here. Today we'll talk about perioperative urine culture. This is a frequent situation in anesthesia. We'll start with a clinical case. Case 1. A 70 years old diabetic man, preoperative urine culture for prostatectomy. 10,000 CFU per ml, asymptomatic. Surgery scheduled in 6 days. Case 2. Same patient, scheduled for hip prosthesis replacement in 1 month. Topic will cover definitions, indication, and management in elective and urgent surgery. First, let's define types of urine culture result. Negative urine culture, sterile or less than 1000 CFU per milliliter. Positive urine culture, we talk about colonization. There is more than 1000 CFU per milliliter, or less than 1000 CFU, but only monomicrobial, or polymicrobial flora. We talk about UTI if 1000 CFU per milliliter or more with symptoms, or more than 100,000 CFU if the patient has a catheter. Symptoms include fever, pain, hematuria, or other urinary symptoms. So the presence of symptoms is essential for the definition of a UTI. Asymptomatic bacteriuria, regardless of the bacterial count, is classified as colonization, not infection. When do we do preoperative urine culture? So always indicated in surgery in contact with urine, like prostate, bladder surgery, hysterectomy. Then we have risk factors to consider in other situations. Diabetes, advanced age, catheter, and living in an institution also. In gynecological surgery, like prolapse or incontinence, if risk factor present, urine culture is required. If no risk factors, we will start with urine dipstick, then urine culture if positive. For urgent hip prosthesis, urine culture may be needed depending on risk factors. Urine culture is not recommended for surgery not in contact with urine. For high-risk patients, a specific management algorithm is recommended, which often includes preoperative urine culture. Conditions such as immunosuppressed patient, chemotherapy, organ transplant, or history of recurrent UTIs. Management for elective surgery. If urine culture is negative, you can proceed with surgery. If urine culture is positive, colonization, so we have two situations. Surgery within 5 days, start empiric antibiotics for 48 hours. Surgery after 5 days, repeat urine culture and give antibiotics according to results. Antibiotic before surgery is strongly recommended in case of colonization. For special cases, for indwelling catheter, antibiotic 48 hours before and to be continued until removing with a maximum of 7 days. For Candida albicans colonization, the diagnosis requires 2 positive urine cultures. Here, antifungal therapy 48 hours before and 48 hours after surgery. Then, if we have a confirmed UTI, we postpone surgery. In urgent surgery, especially in severe cases such as obstructive pyelonephritis, immediate action is required. Perform urine culture and blood culture immediately. Start empiric antibiotics without delay. The choice depends on context. Community-acquired infections, nosocomial infections, and if the patient has beta-lactam allergies. So different protocols are used. So don't forget to adjust antibiotic based on the antibiogram and consider renal function dosage. Returning to the clinical cases, patients represent asymptomatic colonization. For case 1, surgery scheduled after 5 days. A repeat urine culture is indicated. For case 2, no further action is required. Thank you all for your attention.